All good.
Thank you. Good morning, good afternoon, good evening, wherever you are, and welcome to this second WHO and TechNet webinar series on why gender matters for immunization. The session today is about gender responsive actions to improve the quality, accessibility, and availability of services. As I've just said, this is the second series on gender and immunization. We had one last year in 2023, and it was very successful. And we hope that this series is going to be as interesting and useful to you all. You can listen to this session in French. To do so, please click the globe icon, the language you want to use to listen to this session. Now I'm going to say that in French for our francophone audience. Vous pouvez écouter cette session en français. Pour ce faire, cliquez sur l'icône en forme de globe à votre écran et sélectionnez la langue dans laquelle vous souhaitez écouter cette session. We are also introducing a new concept for the TechNet webinars. You can now watch the slides in English or in French. Please let us know. If you see the slides in the language that you don't want to listen to watch. So to select the language you slides in, please click on the view option that is at the top of your screen. Select Stephanie for French and select Michaela for English. So you can switch. I'm going to say that in French as well for our francophone audience. Aujourd'hui, donc, vous pouvez regarder les slides en français, la présentation en français, donc le visuel. Pour choisir cela, vous cliquez sur Option d'affichage, si vous avez ça en français, ou View Option, en haut de votre écran, et vous choisissez Michaela pour regarder en anglais, ou Stéphanie pour regarder en français. Si vous avez un souci, vous pouvez me le dire dans le chat, et je suis là pour vous aider. Talking about the chat, we'd be happy to know who's with us today. So you can already introduce yourselves and tell us your name, where you're from. And you can also use the chat box if you need any technical support. And I'll do my best to help you, especially if you want also, if you haven't understood how to change the slides, let me know and I'll explain in the chat. If you have any question during the presentation, please use the Q&A box. It's at the bottom of your window. It's available there, and you can ask your questions at any time. Our panelists will answer them in writing when they can, or at the end of the session, actually during the Q&A session. Sorry, you're not going to answer in writing. You're going to answer, I guess, orally, right, Stephanie? Yeah.
Yes, we'll try to save time, but of course we can try to address some questions in the meantime. So do ask your questions in writing, and we'll have some time at the end for the discussion as well.
Thank you. Thank you. And in the Q&A box, please. Finally, this session is recorded and we'll share with you the links to the video as well as the slides by email. Thank you very much for your attention, and I hope you'll enjoy this session. I'll give the floor to Stephanie.
Thanks, Alex. And so let's go directly to the next slide, please. So again, welcome everybody to our second webinar series on why gender matters for immunization. As Alex mentioned, this is the second part of a webinar series that we initiated at first early last year. For those of you who are joining us now just for the second half, it's not too late. You can still find all of the recordings and materials from the first webinar series online on our designated TechNet page. The link will be provided. It's here on the slide in front of you. It will also be provided at the end of this webinar. And actually, if I can ask Alex to drop it into the chat box at some point during this call as well, you can visit that page. All of the previous webinars are there and all of the upcoming webinars will be there too. So it's a one-stop shop for the entire set of materials in this series. Next slide, please. I also want to mention, just as we're kicking off today on March 7th, it's the day ahead of International Women's Day that will be celebrated tomorrow. And the theme this year for the UN is Invest in Women, Accelerate Progress. And so this is really a great time to kick off this webinar series in a week that's full of events celebrating and positioning women as the important players that they are in the world stage and in our in efficient delivery of healthcare services. And so one of the main things around, investing in women is also including them and ensuring that they are included in the program design and program delivery of all health services, and particularly immunization. We know that sometimes programs are designed without the meaningful inclusion of women and girls and the communities they're part of. And this limits the agency and also the ability and efficacy of these services in reaching the communities that they're targeting. So this is a perfect opportunity to have this webinar, which will showcase two great examples of programs that have, through innovative strategies, put caregivers and healthcare providers, many and most of whom are women, at the center of their design. Next slide, please. So with that, I'd like to introduce the speakers that we have with us today. We have two panelists who will be providing presentations, and then we'll have time at the very end of the whole webinar for Q&A. But as we mentioned in the opening, if you do have questions along the way, please do pop them into the Q&A box. And so I'll invite our presenters to review that as well along the way and provide any written answers just in case we run out of time. But we are going to make an effort to speed on through so that we have enough time for discussion at the end of the session. So first, we're going to hear from Nin Sumon, who is the social and behavior change specialist with the UNICEF country office in Ethiopia. And second, we're going to hear from Khadija Ibrahim Nuhu, who's also an SBC advisor, but with the JSI Research and Training Institute. So two different examples from two different contexts around human-centered design. Next slide, please. So just to step back for a minute and go back to the guiding document that's kind of inspired this whole webinar series. This is the Why Gender Matters for the Immunization Agenda 2030. It's a resource that was jointly developed by WHO, UNICEF, and Gavi. I hope by now everyone's very familiar with this resource. And this really serves to showcase why gender matters for immunization. We know that gender impacts immunization both on the demand side through people's health-seeking behaviors, as well as on the supply side through the provision of health services, which is what we'll focus on today in this particular webinar. But to increase immunization coverage and equity, it's necessary to understand and address the many ways in which gender interacts with additional socioeconomic, geographic, and cultural factors to influence uptake, access to, and delivery of vaccines. Next slide, please. So the Why Gender Matters for IA 2030 resource outlines a number of ways in which identifying and addressing these barriers can be done through employing gender-responsive strategies. And the guidance document outlines a number of examples of gender-responsive approaches to increasing immunization coverage. And this has been the running theme of this webinar series from the beginning. So in the first part of the series, we covered off 4 different examples of gender-responsive approaches to increasing immunizations coverage. Today, we're going to focus on improving the quality, accessibility, and availability of services. Next slide, please. So, of course, the perceived quality of care, the acceptability, and the accessibility of health services influences the uptake and utilization of these services. This is true for immunization services in particular, and this is also true especially for women. We know from various gender assessments and barrier assessments that women experience sometimes differential behavior and attitudes from health workers and health service delivery points that can impact how they perceive the services that they're being offered and whether they're actually inspired to come back at all. So, for example, disrespectful, discriminatory, patronizing communication and attitudes from healthcare providers have sometimes been reported by caregivers as reasons that they are less likely to return for services in the future. Lack of privacy and confidentiality in health facilities, sometimes immunization services, which might be located far from the communities or from areas where women frequently visit, or low service quality in general, things like stockouts, where, if a woman is investing her time to bring her child all the way to a health service and there isn't any vaccine available, then this can impact how likely she is to return in the future. And lack of healthcare workers who are female in some cases and in some communities impacts the ability of women as caregivers and for their own selves to access health services. Just one example that's highlighted in the Why Gender Matters guide is a study conducted in Bangladesh where women reported that they were avoidant of immunization services because they had fear of being humiliated by the health workers, being scolded, for example, for losing their child's immunization card. And this deterred them from wanting to return for services in the future. Next slide, please. So how can we tackle these gender barriers to improve the quality, accessibility, and availability of services? There's quite a long list of potential actions and examples outlined in the IA 2030 Why Gender Matters guide that can be taken to improve the quality, accessibility, and availability of services. I won't go through all of these on the call today, because of course this is really dependent on the context. And this just highlights the importance of conducting assessments such as standalone gender assessments or including gender-specific questions in any other ongoing program review or program assessment to be able to bring some of these barriers up to the surface to understand what it is that's potentially impacting the ability of women and girls from accessing services, and then therefore designing the appropriate interventions to address those. So I really encourage you to please visit the guide if you haven't yet and take a look at this section because there are a lot of good examples in there that might apply in your context. And with that, I will hand over to our first speaker to give some examples of how this has actually been put into practice in Ethiopia. So over to you, Hin, and looking forward to the presentation.
Thank you, Stephanie. Hello, everyone. This is Nin. I am Social and Behavior Change Specialist with UNICEF Ethiopia Country Office with a focus on immunization and health in emergencies. So today I will be sharing our experience on application of human-centered design with a focus on immunization-related barriers and how we brought in the gender lens. Next slide, please. This is a brief background information about Ethiopia. We have about 120 million population. Half of it is female populations, and full dose of immunization at the national level is only 44%, and majority of the population, about 77%, are living in rural area. And you can also see the education in the rural women communities, which is also intersectionality issues that we need to bring in. The median age at first birth is around 18, 19, almost 19%, and we still have about 59% of home delivery. Next slide, please. So when it comes to gender, the country is still at the gender neutral stage because in intervention we are currently working are using the existing gender roles and relation. For example, like we are still promoting, messages targeting the women, and also compared to women, male caregivers or father, they have the lower knowledge and attitudes when it comes to the immunization and care seeking practices. And also, although there are both male and female participants in workshop meetings, there is limited consideration on intersectionality. For example, women with disability or women in the displaced area or displaced communities, and also the age of the woman, things like that. And also we are currently using the media, utilizing the media and platform which women are already able to access, instead of closing the media gap assess gap among the between male and female. For example, like even for the mobile phone possession rates, males have higher mobile phone possession rate than the females. So those structural issues are like the current situation. Next slide, please. So some of you might be already familiar with this human-centered design approach. Some of you might not be familiar with it. So I would like to briefly go through the process. So it has, to simplify the approach, it is the bottom-up approach. Instead of expert-driven interventions, we identify the barriers and also potential solutions and enablers together with the community. Then the potential solution, we generate the ideas and also co-design the interventions together with community members. So for the first phase related to the journey mapping, I'm going to elaborate a little bit more in the upcoming slide. And the rapid inquiry tools is the stage where we can bring in identifying the barriers and enablers while we are also bringing in the gender lens. And then another stage, which is also critical, is like identifications of, co-designing and also idea generation together with the community members as well as health workers. Then we prioritize, prototype, pre-test, and then we start implementing it. It is an iterative process so that, we have the space to refine and to fine tune the interventions, as well as this is low cost and also, it didn't take much time. Next slide, please. So this is journey to health framework that we are using as part of the rapid inquiry too. So this journey can be for caregiver as well as health workers or vaccinators themselves. So for this experience, I will focus more on the caregiver side. So there are 6 key touch points that we are assessing: enablers, barriers, as well as any potential ideas to tags, and also we bring in the gender lens. So the first one is knowledge, attitude, and awareness, which we have been, focusing for so many years. And the second one is intention, and the third one is for the preparation and cost and effort. That one include, access to the resources, transportations, things like that. And another one is the point of the service. With waiting time for the caregivers, and also the availability of the vaccines, like where they being turned down, things like that. And the fifth one is experience of care, like what was the experience, the interaction with the vaccinators and other health staff at the health facility with the female with the caregiver female and both male caregivers. This is also another interesting to bring in the gender lens, like one of the things that we learned is like male caregivers are embarrassed to be at the health facilities because of there are not many other caregivers, and it seems like something that men would normally do, that kind of norm. So it is also where we identify any potential barriers as well as enablers. And the last one is after service, like did the child has any minor side effect, and what was the experience of the caregivers and how to deal with them. Next slide, please. So for this one, don't worry, the texts are a little bit small and a little bit crowded, but the reason I brought in this, like we apply in selected warrior in Oromia region of Ethiopia. And as you will see, there are different barriers that we identify at the different touch points. And the second one, we also identify any enablers, like different enablers, and also any potential ideas to test. And we put a dotted line on the areas that which we can definitely focus on and also bring in the gender lens. For example, one of the enablers is the father, the male caregiver. They are willing to put the money aside for their children if they are sick or if they need immunization. So we know that this is something that we can definitely strengthen as one of the interventions and things like that. So this is how we bring in when we are identifying the challenges, enabler, the facilitators, and also any potential idea to test. And we brought in the gender lens instead of, making it the whole gender focused kind of process. We make sure that all of those things are aligned and integrated. Next slide, please. So based on those different barriers that we have identified, we prioritize two key barriers that we are going to address. The first one is limited male involvement, and the second one is the gap in the client professional interactions at the service delivery points. So next slide, please. And so after we have identified those challenges, we sit down together with, again, the community members as well as the health extension workers. In our ideation session, the gender is mixed, but we separate community members from the health extension workers because we want to avoid any power dynamic and we want to hear from everyone. So there are a lot of potential solutions that came up, like assigning volunteer to entertain the children and mothers when they are waiting at the facilities, and also to have proper tracking systems, and also community dialogue, and also to empower fathers, and and even to provide a bag of lentils, not only for the mother, also for the father, like one for mother, one for fathers. So things like that. A lot of ideas came in. Then, next slide, please. So among those different ideas, we select like what will be the one that we are going to implement. So for that, we use 4 criteria. So the first one is it desirable to the community? Like community will be interested, and also will it be accommodating for both male, female, and the local communities? And the second one is it easy to implement? Although the idea is very good, would it be technologically feasible? And the third one is, do we have the money to implement that solutions? Like, is it affordable and also even sustainable? And is it even cost effective? And the last one is like, does this intervention has any potential impact in longer term? Next slide, please. So the first priority we selected based on those criteria is the community dialogue, because one, there are ongoing. Ethiopia has a very structured community platforms, like there are ongoing community meetings and discussions, and it is easy for us to integrate gender-related issues as well as immunization-related issues because the participants are both male and female. Next, please. And the other priorities we selected are 2. The first one is interpersonal communication skills. So training. So for that one, we didn't prioritize for the first because it is resource intensive. And the second one, next, please. The second one, which is very critical and very important for us, which is male participation in childcare practices, including vaccination. But for that, as we are I will also elaborate a little bit more on this, going to promote the male participation, and it will also a little bit challenge the existing social norms, which is like women are responsible to take care of their children. It will take longer time for us. So we put it in the second priority. Next, please. So after we conducted the community dialogue sections, what happened? Before, we provided proper training how to facilitate community dialogue sessions to the health extension workers and volunteers. So about 318 of them were properly trained on how to facilitate the community dialogue session with a focus on immunization. And then we supported the community dialogue session with a focus on immunization in the selected cabeles, and about 3,795 caregivers were participated, engaged, and discussed on the local level immunization related one. So we, like, after we implemented the dialogue sessions, we also conducted the evaluation of the, like, we train those people, like this number of people participated, so what? So we collected some feedback and evaluation through the focus group discussions. So we learned that the community members really like this kind of two-way discussion and also a safe space for them in their own local language, and without any other materials or no resource intensive at all. The cost we spend for this dialogue session is only the, some coffee and also some snack, which in some area was contributed by the community members themselves. And also from the community side, they also reported that they have more understanding about the immunization services. And from the health facility sides, health workers also reported they have like increased service uptakes compared to the before we are conducting any dialogue sessions. Next, please. There are some challenges that we face. For example, bringing in, HCD approach, it is new, although our intention is to implement at the village community level. We need to advocate starting from the national level, regional level, district level. So we need to invest some amount of resources for the training so that they will understand, what are we going to do, and, to ensure also they are buying in. And another when we identify another challenge is like sometimes the solution that come up are like instead of groundbreaking, it is also something that is already existed. We are not implying that it is not innovated, but it will also be good in the future ideation session if we can bring in some examples so that people can also get inspiration. Next, please. So way forward, what are we going to do? So we secure some resources for the interpersonal communication skills training for the health extension workers as well as the vaccinators, because the interpersonal communication skills gap is coming up again and again in our different kind of assessments, not only qualitative but also quantitative. And another one is positive deviant approach. For that one, when we talk about the gender in immunization, there are so many different challenges and barriers, including the example that Stephanie provided, um, like decision-making powers and all those things. But what are we going to do? Which one key barriers and issue that we are going to address? So for Ethiopia, we selected the May engagement. So we will be trying to promote the male caregivers, fathers who are well respected by their communities, on the benefits and also the roles of the important role of fathers' participations in care seeking practices, as well as through the religious leaders and other influencers. And another one is, to scale up the HCD application in different regions, not only Oromia, but also in other regions. And also, we are currently using the HCD approach together with the behavioral insight in 10 district. And also, we are planning to integrate with other ongoing program and project. Next, please. And thank you very much.
Thank you so much, Nin. That was super interesting. You can tell also from the engagement in the chat and in the Q&A that everyone has found that very interesting, and there are a number of questions coming your way at the end of the session. So if you have some time maybe to take a quick look through the Q&A box while Khadija is presenting, and maybe try to address some of the questions just in case we run out of time, but we're on track for a good discussion at the end. So with that, Hadija, over to you.
Thank you very much, Michaela. I'm trying to start my video. Thank you very much, Michaela. Thank you for having us. Good morning, good afternoon, good evening to all of the members of the Committee of Practice that have made time out to be with us. Next slide, please. This is what my discussion today will be about. I'll be providing some background into our project and what we do, the strategies that we are using to approach gender integration. We'll look at some of our activities that we have implemented so far, and then we'll look at where we are headed. Next slide, please. So I thought to share, our vision at Momentum Routine Immunization Transformation and Equity with you. So at Momentum, we are about applying best practices and exploring innovations to increase equitable immunization in the countries that we are supporting. We are building capacity to identify and in zero dose and under-immunized children with a view to providing quality vaccination services to people who are eligible for immunization, whether they are underserved, marginalized, or vulnerable populations throughout the life course. Next slide, please. So the Momentum project is approaching gender through these strategic priorities. It is three-pronged. We are collaborating with Gavi, UNICEF, WHO, and other key groups to operationalize global strategies like the Agenda 2030. We are also looking at approaching it in the through the health system pathway as well as the societal pathway. Health system pathway at national level, looking at determining, researching and finding out where and why families are not accessing vaccine services. At the subnational level, looking at timing and looking at location of vaccination services. At the provider level, we're looking to improve their capacity to reduce gender barriers to immunization. While in the societal pathway, we're looking at working with in partnership with community service organizations so that we can implement through them so that they can increase women's involvement in the planning and implementation of activities at that level, also increasing men and adolescent boys' support for immunization services. And at the level of the individual, we're looking to empower women and girls to increase agency as well as their access to accessing immunization services, as well as completing, routine immunization. Next slide, please. So in Nigeria, the goal of the National Strategy for Immunization and PHC System Strengthening is the attainment of at least 84% equitable sustained national immunization coverage with all of our scheduled routine antigens by 2028. This is also in line with the Gavi full portfolio funding. At the MRIGHT Nigeria project, however, we are about working with government partners and country counterparts to demonstrate knowledge, commitment, capacity to design, capacity to advocate for, and capacity to implement effective evidence and gender-based solutions to the entrenched obstacles in immunization through the life course. Next slide, please. So a little about our scope and where we work. We provide technical assistance at the national level, and we work in 3 states: Bayelsa, Edo, Imo, Jigawa, and Lagos. So we're covering the South-South. We have 1 state in the East, we have 1 in the Northwest, and 1 in the Southwest. Essentially, we're covering 774 local government areas, translating into 9,565 wards and a birth cohort of about 7.3 million children. Our objectives are to strengthen governance and leadership, strengthen mechanisms for advocacy, communication, and social mobilization, strengthen health information systems, as well as improve capacity of the health workforce to deliver immunization and primary health care. We are also providing technical assistance to COVID-19 vaccine rollout in Nigeria, in the 5 states and in some of our states. Next slide, please. So let's talk about our discovery year. So for the discovery year, the project conducted 3 assessments. We had a scoping assessment, we had a baseline assessment that covered all the 5 states, but I'll be referring and alluding to this particular assessment that was done in Edo and Jigawa states. That's in the South and in the Northwest. The objectives were to identify root causes underlying the challenges that are related to routine immunization, and to identify assets, good practices, and opportunities that could be leveraged or expanded in order to overcome the entrenched obstacles. We used both quantitative and qualitative methods of approach, and we applied the human-centered design using the UNICEF WHO Journey to Immunization framework. It's important to note that although we did not conduct a formal gender assessment, we were intentional in asking questions that revealed gender-related issues. Next slide. So I will not talk about this. Some of us are familiar with them, and my co-presenter has already discussed this in detail. But it's a framework that we find very important and key, and we have used it. Moving on. Next slide. So let's take a look at the findings, the key gender-related findings from the assessment. Nothing new. I believe other gender enthusiasts on this call will be thinking, oh, there's nothing shocking or no surprises here. So yes, just like the last presenter had spoken, we found that child health and vaccination is considered as women's purview and responsibility. So there's minimal male engagement, male participation, and male involvement in child health and vaccination. We also found that majority of healthcare workers believe that women have leadership roles in the community and within the workforce. This, however, varies. Nigeria is vast. Nigeria is a continent in itself, and we have diverse cultures and diverse people. So across states and within states, between one LGA local government, that's a county, or another local government, we find variations. So it is relative in terms of the population or proportion of women that you have occupying leadership roles. So you would find very few, or we found very few, fewer female healthcare workers in Jigawa compared to their male counterparts, compared to Edo, where the numbers are close. If we move on to the east in Imo, would be surprised by 99% of female healthcare providers, with just about that 1% who are male. We also found that a majority of zero-dose children have teenage mothers, and these young mothers do not have the agency, they don't have the awareness, they don't have the agency or decision-making power to influence the immunization status or completion of their children. This is also linked to improper management of adverse events following immunization. Again, it's the decision makers that decide which child or whose child or when the child is offered or taken to the hospital for immunization. Again, we see that this is happening with male caregivers, with mother-in-laws and father-in-laws. So, and it manifests into refusal to allow mothers or caregivers to return to the facility for the child's next vaccination. We also found that transportation and opportunity costs are also in some areas barriers to accessing vaccines. This is particular in Jigawa, where there is a new incentive project that provides a stipend to mothers for bringing in their children and returning for subsequent vaccines. 50-50, I have my personal misgivings and perceptions about how long we'll be able to make that last. Next slide, please. So to localize our efforts and to implement our global strategy and priority strategies, we've asked ourselves these following 7 questions. We're looking at what principles and policies are in place for community engagement. What system is available for women's participation? How is this system operating in terms of discussions, participation, membership at community level? How do we ensure that there's equitable representation of community members at that level? we're asking, how do we ensure that there's equal value for the diverse perceptions of people's needs and priorities? This is across the states we're implementing, as well as, within the states. We're looking at the modalities for ensuring that there's accountability and decisions that are informed decisions that are taken are also implemented. And we're also asking ourselves and looking at what the feedback loop, back to the community and back to the policymakers looks like. Next slide. So essentially, this is what we are doing. We are integrating gender into the National Community Engagement Strategy. This is the only policy document for routine immunization as far as communications or community engagement is concerned in Nigeria. We are looking at introducing a number of gender-sensitive, gender transformative indicators and checklists into the routine immunization supportive supervision checklist. We are also looking at providing technical assistance that ensures that all routine immunization supportive supervision is gender sensitive. What you see in the bottom right corner of the screen is just an image, a snapshot of what the Kobo Collect tool that is used for our routine immunization and supportive supervision tracking. Next slide, please. I'd like to skip this and move to the next slide, and then we'll return to it. Michaela, thank you. Okay, so what are the strategies we're implementing or using to address? Again, this is directly also linked to our strategic priorities for gender. So at the national level, we have provided technical assistance to the Advocacy, Communication, and Social Mobilization Working Group to conduct a SWOT analysis of the CES strategy. We also provided technical assistance in developing performance monitoring tools, including media mapping tool, media monitoring tool, and to also monitor our overall performance, so a PMP. At the subnational level, we are providing technical support to ensure implementation of the incorporation of traditional birth attendants, women leaders, and civil society organizations into the community engagement strategy framework. This is essentially, or this was essentially proposed, and this inclusion was done to support the traditional leaders for whom the community engagement strategy is designed around. So to support them in line listing and in defaulter tracking. So this is specific to Jigawa State in Nigeria. And this is also because Jigawa State is the only MRIGHT implementing state that has adapted the CES strategy. It is yet to be rolled out in the southern part of the country. Also, we are providing technical support and working on increasing women's participation in ward development committees, community level development committees, and in the development of microplans. To this end, we have informed gender inclusion into the draft operational guideline for implementing the zero-dose reduction operational plan and the reaching every ward micro plan. Next slide, please. Okay, so the next step and other activities that are unfolding right now that we're implementing are working with CSOs. We are in the process of we have mapped and we're in the process of selecting and working with CSOs. So working with CSOs to develop context-specific messages, context-specific community engagement activities, and context-specific micro-planning. So to support states that we are working to accomplish these three, as well as we're being intentional in ensuring that the accountability framework at both national and regional or subnational levels is implemented through the deployment of scorecards. We are also looking at documenting and disseminating findings from the routine immunization, supportive supervision outcomes, the reports, the tracking that is done. And I left this last two for last. We currently we just concluded a first round of testing a set of gender indicators. This is with a view to improving the RISS, the routine immunization supportive supervision checklist that I talked about. So Michaela, let's skip back to slide 12, please. So this is what I'm talking about. We were able to, we curated this checklist in order to test the awareness, gender awareness of the providers this is at the lowest level. So this is really our localization. Curated this checklist to test their awareness of, if you look at the right part of the screen, their awareness of non-discriminatory and anti-harassment policies. We've listed the 5 that currently exist in Nigeria, testing their awareness of these policies, testing if parts or excerpts of these policies are displayed in the facility, testing if there are clear steps, if they've been trained before on gender, if there are clear steps and policies in place for implementing them. We are also testing indicators for tracking and identifying participation of women, female caregivers in microplanning, participation of women in the development of business plans, and also participation or inclusion, involvement of men in activities that are focused on women and children's health. We are also looking at spousal communication, looking at improving communication between caregivers, between their families, between the spouses, because we know that what's important is that people talk, people discuss. Where there's talk and discussion, then people also take decisions, decide on where they are. So let's go back to slide 15. Thank you. So we are testing, we've run the first track, I should say. We will be prioritizing and moving forward with indicators that we can track at an annual basis, indicators that we can track more frequently to support the work that we're doing, to support our localization, and to improve and enhance the technical assistance that we're providing to government at that level. This specific activity will inform improvements in the routine immunization supportive supervision checklist. Next slide. So moving on, for our year 4 project work plan, we have these 5 milestones. And what we've done is to layer gender onto the 5 milestones. So next slide. And we're doing this by ensuring that the CS organization is going to be engaging and working with will be women focused. At least we'll have a percentage of them that are women focused and women led, in order to have them champion gender sensitive community engagement activities in our prioritized locations, health facilities, plus communities inclusive. We are looking at expanding the participants for the visioning workshop that will happen once we have all of our data and we have a clear and we articulate, or at the point of articulating to the state what the strategic thinking and direction of our project in terms of localization. We are looking to expand the participants of that visioning workshop to include women-focused line ministries, departments, agencies, and CSOs. We will also be documenting specifically gender-related outcomes from our milestone achievements, and in EPI review meetings, as well as the dissemination of milestone achievements. We will also be linking the zero-dose indices in our prioritized facilities and communities to the gender barriers in those communities as it unfolds in the testing and tracking of gender indicators that we're embarking on. Next slide. This will carry through our standardization of routine immunization programming, the review of the routine immunization supportive supervision checklist to make it gender supportive, ensuring that the supervision itself is gender sensitive, and also ensuring that there is that gender related activities at settlement and community level are also included in the accountability dashboard. And speaking to this, I'm speaking to the 5 milestones that we have developed to achieve. Next slide. This is my last slide, and I'm sharing this just so we have something to think about. These are the set of proposed indicators that we are testing. It is nowhere, finalized or done. We will be improving and prioritizing on which checklist to move forward, which checklist to present to government in order to better support the Nigerian government at the states and levels that we are working. So essentially, I think the take-home message here today is that we are providing technical assistance at 3 levels. We're providing at the policy level, we're providing at the service delivery level, and we're providing at the community level. The community level, we're working through CSOs to ensure that the activities, the meetings, the messaging, the involvement and inclusion of men are all gender sensitive. So there are exit interviews, and the tool also has a community component where we ask questions, and specifically where we will be layering our gender checklist. So I want to stop here and say thank you to everybody who has made it to join us. Over to you, Michaela. Thank you.
Thank you so much, Adisha. That was super interesting, chock full of information. I know a lot of these slides were really, really jam-packed. So everybody, you'll receive all these materials afterwards, and I'm sure that even upon further reflection, you may have additional questions or comments for our speakers. We do have a few minutes left for questions. I see that Nin has already answered a bunch that have been directed to her in the chat. So maybe while we give everybody a few minutes more to think of any questions for Khadija, I'll ask Nin to answer a couple of these questions live, perhaps, for just to make sure that everyone has the benefit. So maybe we can start with the first one from Erica. She's asking, how did you measure change in awareness and perception? So this is for Nin for the Ethiopia project. Do you want to answer this one live?
Sure. So what we have done is we did rapid inquiry, right? So we have some kind of baseline information because we use different tools like focus group discussion as well as individual interview, and also some card sorting which have different scenarios. So we have those baseline informations because in the rapid inquiries we identify a lot of issues, or it might not be statistically how can I put it, because those are qualitative, small-scale ones. So after the implementation, what we did is also we did more or less the same things, focus group discussions, and also, identify like what kind of change that we really see, things like that. And also we have utilized different questionnaires, different set of questionnaires, including the WHO's BESD tools. So yeah, this is how we measure. Over.
Thanks, Nin. And so maybe the next question, I believe it was directed to Khadija because it was posed once you started speaking, but I think maybe it would also apply to the findings from Ethiopia. But Khadija, Noshaba is asking, the findings that decision-making that caregivers didn't necessarily, especially young mothers, have the full agency for making decisions about seeking vaccination services. Were you able to dig a little bit deeper and understand whether the decision-making and potentially refusal was actually about choosing to vaccinate, or is it more about accessing services and the ability to travel to the facility?
Thank you very much. I think it's a combination of, all three. It's not having the agency to be able to decide. Again, that's also linked to not having the awareness about vaccination and the utmost importance of vaccination. It's also related to transport, because if the young mothers lack agency, then somebody is going to have to provide a means for transportation to get to the facility. So that's also a factor. The third factor is that of the AEFI, the adverse events after vaccination. This we have found as one of the reasons why that also happens. If a baby, for example, in the perception of the mother-in-law or father-in-law, is if the baby is perceived to have had a slightly higher temperature than normal, maybe compared to other children after immunization, the power holding members of the family are likely to now say, no, don't take this child back. I encountered this very recently in the south of Nigeria in Bayelsa, and the under-immunized child that we found in this case that was already 6 months had only taken the BCG. And the reason was the mother-in-law decided this fever was too high, don't take the boy back. I hope this answers the question. Thank you.
Yeah, I think it answers it very well, and thanks for that very thorough response. We do have time for one more. This one is to Nin. They're flagged as anonymous, so sorry I can't address you specifically, but someone has asked about the sample size among caregivers and asking whether you feel that this was essential for saturation if replicated elsewhere. Is this type of thing generalizable? I think your response was really interesting, so hoping you might share that for the group as well.
Sure. So it is very small sample size because we are focusing at the community level. So it's not generalizable. In one session, it's only about 15 respondents. About 8 of them are caregivers, parents, and the rest are either health extension workers who are vaccinators or mobilizers, and some leaders. So it's not generalizable, I would say. And also the core value of HCD approach is to identify local level solutions, local level barriers, and to ideate and to implement local level solutions, which is low cost and also more sustainable. So it's not about the national level representative kind of things. Those are small scale, rapid one at the community level. Yeah.
Thank you so much. I see one other thing that keeps on coming up is the desire to have these materials shared, which we will absolutely share, but also I know that there's been a few requests for the report for this Ethiopia work, and of course for the Nigeria work, if there is a report available as well. So if there are links to be shared, then this is a request to the presenters. Please share them with us, and we can ask Alex and the TechNet community to send everything around to our very large mailing list that we have now through this TechNet registration. So everything can be shared with everyone on this call and everyone that's registered for all of the webinars. A reminder that if you are registered for today, you're automatically registered for the remaining webinars in this series. But please do continue to share the information with your colleagues, with your network to join the subsequent webinars because we want to reach as wide an audience as possible. I think that we're just about out of time and we're going to lose our interpreters at the end of the hour. So maybe I'll close there just to say a big thank you again to both of our presenters and also to Alex and Michaela for facilitation and organization of this webinar series. I really hope that everybody enjoyed it and looking forward to seeing you all on the next session. Alex, do you have anything to add before we close?
Thank you very much. Well, thank you to everyone who participated to this session. And yes, we will see everyone. We hope to see everyone on the 4th of April for another session on empower and collaborate with civil society and change agents to overcome gender barriers. I think we can close this session. So again, thank you to our panelists and to everyone. And we wish you a very nice rest of the day. Bye, everyone.
Bye, everyone, and happy
Bye,
International
everyone.
Women's Day tomorrow.
Bye.